I was born in this land. I learned how to breathe in this land. It was this land where I felt free. It was this land where I tasted the salt of the seas. It was under these balloons where I made my wishes. It was these paths where I took my journeys. It was these lands that I love.
There's a lot of histories about it. One of the doctors involved in the protocols was actually involved in trauma because he crashed his airplane, his personal airplane with his family, and he saw such an enormous amount of incoordination, and when primary care providers, ambulance, paramedics arrived to the accident, that all his family died. And the legend said that that's the beginning of ATLS, or the Advanced Trauma Life Support to do. So this is a little bit of collection of things who have been published. There's a large amount of publications about trauma, and some of them are really, really more bibliographic recollections of what has been published. It's impossible to avoid any reference from humans because these guys are way ahead of us. Trauma is actually the most important cause of death in people less than 25 years old. So still, humans are trying to figure out how to save more patients. So in veterinary medicine, there is a general interest in the community who work on emergencies, and that lead to the creation of a group called the Veterinary Committee in Trauma, who is a group of specialists, emergency and criticalist people who has been working on this, trying to organize this. Why? Because one of the main causes why these patients die is because it's a mess. Everybody tried to do something and nobody lead or organize this. So the organization of trauma patient is probably the most important part, and what everybody is researching. What we can do, what we can do better, what we can do different. So a lot of this, and of course lately with new technology coming into the table, there's a lot of new things as it happened during the beginning of 2000 with the ultrasound. Now it's tomography, and lately probably is going to be MRI, and that kind of new technology. How much we can do it? Yeah, at the beginning was very prohibitive for veterinary medicine to use it because it was freaking expensive. But today, the equipments and technologies are getting more and more affordable, so more people can use it. So there's a very classic papers right from, icons of emergency veterinary medicine like Dr. Roberts here and Choffer, this was from 1994, who was already trying to organize a scoring system. So how you can say this dog who was hit by a car is more severely sick than this cat who fell from the balcony on the third story of a building. And the paper down there is 2004 or 5 that was written by Dr. Muir. Dr. Muir is an anesthesiologist and criticalist, an icon and a monster of the emergency and veterinary knowledge. These two guys probably have more papers than all the rest together, Roberts and Muir. So they're very classic. If you want to read about it, find them. They're free to access now. And this one are the new ones. The new ones, for example, up there is trying to correlate what they found in tomography with what they found on gas analysis in this type of patients. So there is a direct correlation. So patients who have worse images in the tomography tend at the same time to have worse blood gases analysis, or no, they run for different. For a lot of times we think that, okay, it has to be logic, like the ones who are more sick and more severe, traumatized with worse tomography or worse radiograph should have worse analysis on blood. You have to have more anemia, more hemorrhage, etc. But surprisingly, that is not the case. So down there is probably one of the biggest steps has been done lately, who was the validation of a new score. Again, one of the huge things here is how you can tell how sick is a pet. In a lot of countries, there's a lot of intuitive on this, like in Spanish, say the ojo clínico, the clinical eye, that somebody with experience look the pet and say, oh yeah, this is really, really screwed up, or no, this. in my experience, and I've been doing this for quite a few years, you cannot predict this. A lot of times you think this guy is going to die in the next hour, and one day later he's going home. And other patients after trauma looks very stable and with minor injuries, 2 hours later develop pulmonary contusion, hemoptysis, and they die from pulmonary hemorrhage. So there's not a very clear picture at the beginning. So these guys have been working on that. How can I do that? And trauma is easy to talk, but it's not easy to see. And you have to see this. Do not forget about this, because this is trauma. It's an unexpected event that nobody want to be part of that. Wow, whoa, what happened here, etc. Think what happened with that people, what happened with that dog. In humans, everybody know what to do, and they immediately start calling an ambulance and calling the doctors or the police or 911, whatever phone code. In veterinary medicine, it's a little more paralyzing. These guys, oh my God, what should I do? Should I call the owner? But the owner is going to be pissed off with me. So, should I call a veterinary? There's no ambulance in majority of the part. So there's a delay in this. It's very traumatizing. Everybody feel, in the majority of the countries in love with dogs. So be involved in such a thing. If you ever run over a dog or a cat, you're never going to forget it. So it's very traumatizing. And this is the person who arrived to your hospital. Don't forget about that. They come out with a lot of guiltiness, a lot of upsetting feelings. They never wanted, they were going to the beach for a weekend, and now everything upside down. The owners are crying because the dog is adorable, etc. And you cannot forget about this. This is also trauma. So, don't see it again. This is a brand new protocol published who essentially addressed something that we know that happened, but we didn't knew what to do. And essentially is the usage of cardiac troponin, who is a serological test, compared with electrocardiographic abnormalities. We know dogs after trauma can present arrhythmias, but we didn't know how to predict that. And essentially the only recommendation is monitoring. The funny thing is a lot of these patients don't even have chest trauma, don't have thorax trauma. They have pelvic or abdominal trauma, and nevertheless, they can develop arrhythmias. So this paper proposed the usage of cardiac troponin as a predictor of severe arrhythmia, and it's quite interesting. So again, so the score bed cut is probably the biggest step, as I told you. And what they did is essentially mix two scores previously used. One is the animal trauma triad, and the other one is the modified Glasgow. So both are independent scores that they're going to be using together and to get a final. What is the good thing is I'm going to explain you. The ATT, or the animal triage trauma score, is evaluating 6 areas of the patient. Perfusion, cardiac, respiratory, eye, muscle, skin is just 1. Skeleton and neurologic. And each of these 6 areas are evaluated from lesions who goes to 0, who are mild, to 3, who are severe. So you classify all these 6 areas and they give you a score, a number. The modified Glasgow evaluate 3 areas. That came from human, and what is modified? Because the original Glasgow was used in humans to evaluate cortical function, so brain function. So they ask you questions like, we show in the movies, how many fingers are this, what is your name, what date is today, etc. So that evaluate motor activity, brainstem, reflexes, and conscious level. It sounds really complex, but it's very simple. It's probably the most nice thing about this score. Is simple to do. When you combine these 2 scores, you can predict with 91% accuracy who's going to survive and who's going to die. And that is awesome. It's way better than in humans. So it's something that we should discuss a little bit more. This is the classic patient of trauma. And in cats, there's another factor who is quite common: no witness. They don't know what happened. The cat show up in the house, or somebody found it on the street, or she fell, etc. And cats are very particular individuals. We know about this, and trauma is not different. Traumatized cat is a lot of questions, a lot of like enigmas. So there's another one. Let's see this case. This guy get caught in a wire and pretty much hanging out himself. So what kind of research has been done lately? I want to discuss today probably one of the biggest ever study done in trauma, who's called Veterinary. It's an analysis of a little more than 20,000 cases, and it's made in 9 different countries, including USA, Canada, Australia, and Europe. So that was run from 2013 to 17. It was done in dogs and cats, and this study create a particular record for trauma. So those hospitals have to fit it up that trauma. Why they investigate this dog, by the way, the one on your screen, it was a Shar-Pei who walking into a golf club during the night. Nobody know how, but she was attacked by the guardian dogs of the club, who were 5 German Shepherds. I never see a dog with more bites in my life. She passed away, and that is the expression of inflammatory response. So there's a lot of, I don't know what to do with rising hands, sorry. But we can take questions probably at the end of that. Thanks. So what data they collect in these 20,000 cases? Obviously, demographic data like species, age, breed, and sex. What type of trauma was a contused, was penetrating, blunt trauma, etc. What was the source of the lesion? It was because it was hit by a car, or was a fall, or was ammunition, impalement, etc. They give it a score, severity score, who was the one proposed it for you. And they also record if they use diagnostics, what? CDC, CAN, they measure lactate, they did electrolytes, they use images or not. And the other thing who's really, really nice in this study is how many of these cases need surgery in trauma? How many of them really gonna need a surgical treatment to get out of the situation? Also, they recorded what pets need hospitalization, for how long they remain, and a little analysis of the population who require hospital. The other who is very common in humans is how many of these guys needs blood products? How many is gonna need some sort of blood transfusion? In humans, this is critical because they need to have a blood bank. In veterinary medicine, it's not that common. We use more donors than having blood banks, but if you have an emergency hospital, likely you're gonna have a little bit of blood product like French frozen plasma or cryoprecipitate, and likely some sort of blood or red blood cells. And the final data that they collect, what happened with these guys? What was the final outcome? He did survive, he died, or something that do not happen in humans is it was euthanized. And that's a tough question. If the pet was euthanized, what was the reason? So keep your eyes on the right side of the screen. This is something that especially happened in trauma in cats. And is what you see this, the lady walking is not ignoring, it's just she don't see this happening, and she don't see that poor cat spinning and jumping, etc. I think the taxi went through, but as many people don't know what to do. Should I stop? What should I do, etc. And the other cat's screaming. The cat is sitting there, and in a lot of cases, they just pass on the street. If he survived, there's a really long time since he was hit by the car until he received care. And that's one of the big differences in humans. How much time happens since you were in the car crash until you are seated in the hospital? In the animals, depend that somebody find it, it looked like the poor cat just passed, etc. So cats are very particular about trauma, again, because a big chunk of the trauma cases, nobody know what happened. So they do not see what was the origin of the source of this. So In this study, when we found how many dogs and cats, like everywhere else, the large majority were dogs. Around 83% of these cases were dogs, 16% were cats, and the demographics are a little bit different. I know a lot of countries that it's not very common that they neuter males, so the majority of the males are intact. That's not very common in cats, but those are the numbers. Again, the majority of these animals are neuter or spay, both females and males. So the distribution is the classic ones. Don't play with porcupines. If your dog is playful and is kind of like a hyperactive dog, this is what's going to happen. So how many of these animals receive primary care? This was an interesting question. Around 30% of them went to a general practice. What really caught my attention that there is a small amount who receive care from non-BVMs. And this is the next door neighbor who used to be a nurse in, I don't know, 20 years ago. They think they know, or they have a friend who was married with somebody who was in veterinary school for 2 years, and they try to help and provide first aid, a lot of times with pretty bad consequences. So trauma cases, please protect yourself. There's blood and other liquids and fluids that you should be protected against. We're really bad for that. So type of trauma, again, blunt trauma seems to be very important, but this is one of the surprises in the study. We found out that dogs actually have more than 50% of them have penetrating trauma. And that was like, whoa, we never expect that. Because when we talk about penetrating trauma, we think about knives, swords, arrows, that thing. But there's one factor that is really making this different, who are bites. So in cats, blunt still is the most important thing. Again, we not have many of them with a clear picture. So why not? Because this is what happened in cats. They combine traumas. They insult. And from the penetrating injury, they felt like too, they do not stop fighting and they keep going. And it's just amazing. So fight cats, I don't want to keep fighting with this cat, but it's just amazing. If in humans, something like that happened, you die after you fell, but cats are not, and they keep fighting. So 2 hours later, he realized has a fracture in the femur or a pelvis. It's not limping, and the owners had no idea what happened. They just heard the fight. That's it. So in the type of blunt trauma or contusion trauma, hit by a car seems to be the most important still, followed by falls. In dogs, a big percentage of this is from medium heights, like from the table or the board of the kitchen in small dogs. So in the case of cats, that came a little bit more from buildings, balconies, and that kind of thing. Something that it was investigated, still is not that important, is the amount of animals who is around 8.8, 8.2%, much more common in dogs, who receive trauma traveling inside a car. They are free to move inside the car. There's an accident, or the owner just hit the brake, or a very speedy maneuver, and the dog hit one side of the vehicle. A percentage of them ended up in the hospital. So again, the rule of dogs and cats inside vehicles should be secure with some sort of seatbelt is very important. Even if they travel in carriers. In carriers, they travel a little more safe, but it's just a small vehicle. Crutch, some people ask me about that. Crutch is a compression. The classic thing is a little puppy who was in the floor, kids are running, one of them stepped on the little kitty or the little puppy. That's the classic crutch thing. The other classic crutch lesion in cats is the cat sleeping under the car of the owner. The owner don't realize, they move the car and then find, oh, the cat is under there. What I can remark, again, is the enormous amount of odors in cats. That includes unknowns, who means I don't know what happened to my cats. It just show up like this, bleeding, or with these horrible wounds, or no moving, etc. This dog belongs to one of the nurses in the hospital. It was her loved dog, a little pit bull, and she showed up after being hit by a car by the next door neighbor. And at arrival, you can see lactate is kind of elevated. She spent 5 days in ICU, but she pulled it out. She went, and I don't know, 2 weeks later, they have to go for a couple of surgeries, repair pelvis, one of the femurs. At that time, 24 hours later, she had to repair a bladder, who was ruptured. So she did a lot. So tough animals. If I'm talking about penetrating trauma, the bite is for far, especially in dogs, the most common source of penetrating trauma. In cats, it's a little bit more different, but impalement is not uncommon. We see a couple of very impressive cases of dogs or cats impaled in fence. They try to jump out of the house in a fence, and they just get impaled there. I'm going to show you some cases. Ammunition is not that common. In dogs, in general, there are accidents. And the same happened with glass and metal. They normally, dogs running in metal, we see a lot of on wire fences. Dogs, the one that you saw there was almost decapitated. I saw one yesterday, and in a cat, who classic, they get caught in a wire, and instead of move backward, they keep pulling. So they have pretty nasty wounds, penetrating trauma of that. So this is one. This is a construction bar. Nobody know what happened. The cat is alive. And I always say this, please, if you see this with an arrow stick, an iron, don't do what they show in the movies, like they give you a shot of whiskey and they pull it out. Don't do that. You have to go to surgery with the foreign body in position to be removed. So it's very impressive. What clinical approach happened in these animals? A percentage of them, around 20%, went to ICU, very intensive care. What is interesting here is how different these guys are from humans. Only 13% of dogs and 16% of cats evidence signs of brain trauma. This is way different in humans. We have a percentage around 30 to 40% in multiple trauma, car crash, or that type of accident with brain trauma. Is even low for spine trauma. Also interesting is how much the ultrasound has penetrated this with the abdominal AFAS performed in a 20% level, 25%. And the TFAS, who is gaining terrain, it needs a little more, it's more new, it's much more new, but it really required a little bit of different type of training. How many cases of this need surgery? This is very similar to humans, around 43%, half of the cases in dogs gonna need surgery. What this implies is the implication for hospitals. That's mean, buddy, if you wanna work in emergencies and you put a sign of your hospital, emergencies, you need to be ready to do surgery in 50% of the cases. So think about it. If you have a place, if you have anesthesia, if you have machines, if you have nurses, and overall, if you have the surgeon and the anesthesiology or your technician capable to do that, doing anesthesia and surgery in trauma cases is nothing to do with a preventive care surgery. When you have time, you can make plans and you follow a schedule. A lot of these cases, you have to jump in. So think about it. And the need for blood was not as important. And one of the questions rise for this was they didn't use blood because they didn't have it, or they never needed. So a lot of people use just regular crystalloid fluids or some sort of a blood product like fresh frozen plasma or albumin to replace that. In humans, this is a little bit different. They have access to large volumes on the blood banks. So if you have a relative or a friend who has severe trauma, they're always going to ask for donors. So they always work on refill and replenish these blood banks. So, yep, you need to be ready in trauma cases to use some degree of anesthesia. And, well, it depends what you have. So, at the outcome of these patients, from 17,000 dogs, the survival rate is 92%, who is awesome. And in cats, is 82%. When you go for death, natural death, pets who die from trauma in hospitals is very low, 1.3 and 1.4%. It's similar to coronavirus. Euthanasia is way higher. It's like 5 times higher in dogs, but it's like 10 times higher in cats. And this is very, 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 very attached to the type of owners. Cat owners are way more emotional. The majority of those euthanasias has to do with the perception of the owners that the cat is suffering. So cat owners are way more sensitive to that concept of the cat is suffering, I don't want it to be in pain, etc. No, I prefer to go to sleep. When you ask them the reason for that, bad prognosis is the lead factor. Financial is another factor. Some people is honest about it, say, sorry, I can't do it. And that happened here, what they do in the hospital. It has to do with individual. There's a nice study that is in Japan about if genetic plays a favor this, and it's very likely. Genetic played a factor for in cancers, and a lot of survivals today in the coronavirus seems to have a factor too. Why somebody just survive under the same circumstances, another individual, same age, same comorbidities, etc., do not. And humans seems to have another factor too. So one of the things they're trying to do is evaluate how severe is this patient compromised. This is a classic index. It's called severity index, who essentially evaluate how much is the compromise, the anatomy part and the functional part. So give it certain numbers to that, and open fractures, if the face of the neck is compromised, etc. So the whole idea about the severity index is give you a number and say, you know what, the index is 45, there's an 80% chance that this patient is not going to survive. This is a very common source of trauma in our field, who is animals attacked, small dogs attacked by large dogs, what in American call interactions. This is a common source for trauma. We see this a lot, and I don't know. I think it has to do with the concept of certain humans who believe that their dogs are kids, so you can't educate them. They forget their dogs, and until they behave like dogs. So this is an index called trauma severity, and evaluate certain areas like circulation, breathing, abdomen, motricity, and language, as you see on the left side of the table. And you can graduate that from 0, 1, or 2, depending if it's normal, affected, or severely affected. And that creates you a number. If your number is below 9, it is considered your trauma is mild trauma. If it's more than 9, it's considered severe
Orada
trauma.
saksıcılar var.
Yeah.
Yok bu daha erken. Hiç bak görüyor musun, hiç yan taraftan sesi yok. Kafası iyi değil ya. Aynen. Atıverse.
I didn't know what happened. You heard me? I don't know. I was able to hear somebody there. Can I keep going, right?
Yes, okay, no problem.
Okay, cool. So there's this score trauma, who is a combination, is similar to cramps trauma, and it's a combination of Glasgow coma scale, who is intended to evaluate brain trauma, with an added of systolic blood pressure and respiratory rate. Obviously, the higher points are more survival, the lower points are less survival. And that's, again, looking for how to direct and efforts and provide some sort of prognosis. Burns are another form of trauma, so we should evaluate these patients who have severe burn surface or degrees as a traumatized patient. There's a lot of tissue damage, there's a lot of fluid loss, etc. So burns are a particular type, but it still is considered a form of trauma. It's a physical factor. The injury severity score is purely anatomic. The body of the patient is divided in 5 areas and evaluated from 1 to 5. The areas are the head, neck, chest, abdomen, extremity, external, and that area you evaluate from 1 to 5 on severe. 0 severe, so very mild is 0 or normal. 1 is really mild, and 5 is really, really serious. So when you evaluate these 3 areas, you elevate to square, and that gives you a point. So the square is to eliminate difference. I don't know, with veterinarians, we're not good with math, but also provide a severity score. So what happened in veterinary medicine? There's a lot of usage. One of my big good friends, we work with this in Dr. Mele in Argentina. They create the same. They use the injury severity score in humans applied to veterinary patients and divide the body in 5 areas: head and neck, soft tissue, abdomen, thorax, limbs, and evaluate the severity from mild, moderate, severe, and very, very severe with life-threatening conditions. So you give it a point at this, and you get a number. That was the beginning of scores at that time, and this is the modified Glasgow. It's really, really nice because it's simple. You evaluate moderate activity, just that, from 6 to be normal, to 1, who is the pet who cannot walk and do not have any reflexes. Brainstem reflexes is essentially oculocephalic reflexes and pupil reflex. Normal is conscious and direct, and bilateral unresponsive mydriasis, we know, is the worst. And the other one is the level of consciousness. How awake, how is the level of mentation of your patient from normal, alert, and responsive to comatose where they do not respond. They give you a point, and when you do this from the point of view of brain trauma, modified Glasgow scale from 3 to 8 is considered great. 9 to 14 is guarded, and 15 to 18 is good. One of the good things about this scale for brain trauma is when you compare patients with the same score between humans and animals, animals are way better surviving head trauma compared with humans. You humans are not really, really strong. Again, ultrasound, there's a lot of new research with ultrasound, but essentially it's very useful, it's very dependent. And the tendency is try to use it bedside, so not in a radiology room, etc., but with a little equipment who provide information right away when the patient arrives. So it's very much part of the triage now. And this is the animal trauma triage score. This is the most intense triage system where you can see you are evaluated from grades 0 to 3. 0 is almost normal, 3 is severe, and you evaluate 6 areas of the body: perfusion, cardiac, respiratory, eye muscle integument or skin, skeleton, and neurological. So you integrate this, so you're gonna get a final score on those 6 areas. So obviously, if you have an 18, you're dead because that means all these 6 systems are severely, severely damaged. So if you want to Google it, you can find it everywhere. It's the ATT score, or Animal Trauma Triage score. So what we have learned from all this, we have learned a lot. And the question what we should ask is, are we saving more patients now that we used to do 20 years ago? And the answer is not that clear, but it's positive. The first thing is what we can measure. This is a new job in and in cats who were attacked by dogs, and they did the animal triage, trauma triage score, and they found what parameters they can measure. The good thing about this work was published in 2019, just last year, is these 4 factors. Remember, this is cats. Lactate can differentiate between severity, calcium, magnesium, and the pH of blood. Those 4 factors can help you to drive. And probably the most simple of all of these is lactate. Ionized calcium is different than total calcium. You need a specific. And magnesium is part of some chemistry panels, but I don't know if you have it. What else we have learned about trauma in the last years? Bites. Do not trust bites. Bites can have a very tiny hole in the entrance, but can have severe damage under skin. So bites, especially in abdomen and super especially in thorax, needs to be explored. One of the common complications in trauma patients are bites who are underestimated. The doctors feel that it's just a little small wound, no worries, it's going to be fine, send it home with some pain medication, antibiotics, going to be fine, and then realize that there's this huge damage underneath. So what we learn is no individual parameter. Magic do not exist in trauma. There's no one thing that you can measure who's going to tell you how the story is going to tell. So you need to put a lot of parameters on board: temperature, respiration, albumin, lactate, blood, etc. Respiratory rate and level of mentation is very important. So there's no one parameter who's going to tell you how good or how bad is the future of that patient. With also thing that learned is what happened in the first hours after trauma has definitely a final effect on the outcome. So this is something that most of the time has to do with the owners and how much they want to wait for this because they feel it was not that important, and they wait because the dog seems to be doing fine and blah 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 blah, and 2 days later they come back to the hospital and say, yeah, he had a little accident, he was fine at the beginning, but now he's not doing fine, he's not eating, not drinking, check the way he breathes, etc. So when you wait in trauma, mortalities go high. This is a very common effect. Small bites on the airway that the owner fitted up, that and they come back to the hospital and say, after he was attacked by the dog, has been gaining a lot of weight. No, lady, you have subcutaneous emphysema, one of the bites penetrated the trachea, and that's what you have now. So again, timing is important. The other thing that every single study in humans and in veterinary medicine make very clear, trauma affects everybody. Nobody's indifferent about trauma. The cases are complex, they're life-threatening conditions with a lot of complications. The fact that most of these cases are unexpected put the owners and everybody involved in weird positions. Owners are upset, anxious, sad, frustrated. Finances play a big factor. I'm imagining today with everything what's going on, I heard a lot of that. I'm sorry, I'm not working, I was fired or laid off, etc. So euthanasia for this reason becomes a real option for these pets. So think about it. We're pretty tough on judging clients sometimes, but it's really, really, really frustrating for some of them. The other factor that is clear in every study, if you don't prepare your team, you're going to have 70% higher mortalities. You need to train your people. You need to tell them what to do. You need to tell them where's the equipment, where's the crash cart, what do you do first, etc. One of the things that we did when I was in Chile, we did a study like, what did you do? What is the first thing you do when you receive a dog hit by a car? And the variety of response was impressive. from everywhere. I mean, this TPR measure temperature or inspection or no. Immediately I clip and I put a catheter. I start giving fluids. I start giving sedation. So probably not all of them were correct, but which one is first? And that is something that you need to talk with your team, or you're going to lose more patients than other hospitals. The epidemiology seems to be the same that in humans, young individuals, intact males, that is also true in humans. Majority of the males are intact. Large breeds seems to be more common, and outdoor cats. So if you have another argument to discuss owners who want to have the cat outdoor or indoor, this is one. Outdoor cats has 6 times more options to suffer a severe trauma. This demographic data is very variable, it's different in US, in Europe, in Latin America, in Turkey, and Eastern Europe, the way that they treat animals and they, have a relation with them, they're intact, non-intact, outside, inside, etc. Timing. And this is, from my point of view, the most critical part if you don't have training. Is like, you always think, oh, I should be doing this, or I should wait. Should I start transfusion now, or should I wait? Oh, the dog is having arrhythmia. Should I use beta blocker, or should I wait? Maybe I have to use sedation because it's very dysphoric. So training should provide this, a good sense of timing, when and what decision needs to be done. There are key factors to achieve success, and when you go to surgery, etc. So triage is critical. What do you do, and how you ask questions, how you prioritize this. In humans, there's a way more systems. In veterinary medicine, it's not that, because include estimations. A lot of times the clients want to know if my dog is going to do it, or is it going to make it or not. So, but triage is critical, and there's people who's really good with triage. How you know it's good with triage? When you ask questions of your nurse, hey, when this happened? And if he answered, I don't know, I didn't ask that, she's not the right person to do the triage. The triage nurses or technicians need to ask every single question. So if you ask that, they should have an answer. When this happened, how this happened, etc. You don't need to know when the rabies vaccine was, but you need to know how much time ago it was, if the dog vomited or not vomited, if he lost consciousness, if he's bleeding, how long has been breathing, etc. So triage is important. That includes the phone triage. You need to ask the right questions. You need to have a timing. And this is important for many things. One of them is you need to communicate to the rest of the hospital, hey, this case is coming. There's no point to tell, I'm going to bring, a client called and said he was hit by a car, it's coming. What happened? I don't know. The client said that he was hit by a car, but his conscience is bleeding. I don't know. He said you need somebody, you need to train your reception or whoever take phone calls to ask the right questions. Why? Because you need to prepare. Every time that you prepare, you are gaining time. You need to set up the places, and you need to prepare for what's coming. So remember also that do not give recommendations. And this is also variable depending on the countries. But in some places, you have legal issues. If you recommend things like, I don't know, put in a splint or apply some bandage, etc., don't do it. My main recommendation is always come back to the hospital. Come to the hospital right now. We have to see it. We have to touch it, okay? The other factor who is taking an enormous amount of efforts and research is pain. These diagrams was made by a Canadian group who developed, actually is Brazilian, who developed a face expression diagram to evaluate pain in cats, and it's awesome. It's really, really important. And they remarked the fact that pain is important. Many years ago, pain was a factor to use against the animal. Let him that way so he doesn't move no more. today that is not only anti-ethical, it's anti-medical. Pain should be assessed and treated. Assessed and treated. And here is all your options for treat pain. My only message, this is very different depending on your country, what you have access, if you have or not access to opioids or not, what is the legislation about it. What I'm going to say about this, you need to think about it. You need to think about pain of your patients in trauma. It's not something that later on, or no, I'm just going to give a little bit of whatever. No, think seriously. Pain is one of the factors who really can worsen the prognosis of your patient. There's another, and today there's a large amount of resources, local blogs, ultrasound guided blockage, sedation who can accomplish that, acupuncture, and there's an enormous amount of drugs and combinations, protocols that you can use. Whatever you have available, please use it, but do not forget about pain. That is what all the research prove today. If you take care of pain, you have better outcomes. And this is a very interesting part, surgical timing. In humans, there's some specific research. For example, you have a dog who was hit by a car. He was a spleen rupture, so he's bleeding, he's hypotensive, hypothermic. But also you have a fracture in the femur. So you start sterilizing, you treat pain, you treat fluids, hypovolemia, you give transfusion, you repair the thing. When you go to repair the femur, so that thing, in general, what we used to do is damage control surgery. So you do all the surgeries who correct life-threatening conditions. But when you have the other type, when you go to do the surgery, 48 hours, 72 hours, etc. There's a good amount of research on this area in humans deciding when is the surgical time, because what they prove is you have a window. You have a window of opportunity who is, if you go before 24 hours, you kill more patients. If you go after 72 hours, you kill more patients. So that article is really nice. It was in 2015. There's a new one in 2018 about when you should go to surgery in these patients, especially in trauma patients. And just a little comment. This is a new drug that we used to, it's not new actually. We had this during the 80s and we didn't pay attention, and it's gaining a lot of attention now because has proved that improve survival, particularly in traumatic brain injuries and TBI, but it seems to work very nice in trauma cases. So pay attention to tranexamic acid. It has to be injectable, and they're oral, but you want injectable. Seems to be safe. I think there's a lot of still to be investigated and research about it, but it's a very interesting new drug. It's not, again, not new, but it's back. Let's put it that way. New things, again, the use of computer tomography. I remember Farfallini, an Argentinian guy, say that it's not axial, so do not call them TAC tomography. It's just computer tomography. And because now it's more available, there's new studies on that. And obviously, when you can and you have available, the use of whole body tomography provide an enormous amount of good data. So yeah, now it's still very expensive, but the same happened with the ultrasound, and this happened with monitors. The first ultrasound that I worked was in humans, and it cost $250,000. Now you can buy a pretty nice modern ultrasound for, I don't know, $12,000-$15,000. So the same happened. Eventually, tomography is going to be more common and more available. So what we must to say that the god of death for trauma, remember this: if you have a patient who is in threat for trauma, not today. And I want to invite everybody for the Tuvecca Congress, who's going to be done in December, if everything goes fine. It's emergency and critical care. We're going to be there talking about gastrointestinal emergencies, abdominal emergencies. So they're all of you, the Pandora box mysteries and the gastrointestinal disease. So that's it, guys. Thank you so much for being here. Thank you. Gracias. Pasivo. Merci. Obrigado. Arigato. Danke. Multimesk. Thank you so
we
much.
have a couple of questions in Q&A. You
Okay.
can answer them. I think we have some time.
Okay. Okay, let's go ahead. What I need to do.
You have to open the Q&A down.
Oh, Q&A.
Down there. Yeah.
Q&A here. Okay. Hello, Mr. Tello. Thanks for representing. Which triage scale for you use? We use a more complicated one. It's called Apple, but I use the ATT. The ATT is the animal triage. It's six parts of the body when a scale from 0 to 4. Yeah, that's what we use. Dosage is very variable. Please looking at you because there's no one concentration. It's around 50 to 100 milligrams per kilo. Which setting is coming for aggressive cut after major trauma? I mean, we try to stay away from the dexdomitor. If you have time, you can try gabapentin. We have a fast gabapentin. If not, what we use is a combination of ketamine with butorphanol. We also use ketamine with midazolam. So that's what we use the most. And thank you, Tuvecca. That's it?
Yes, I think so. Thank you so much, Tello, for this great presentation.
You're very, very welcome. I'm happy to be part of this, and I hope you enjoy it and can provide a little more information. And thank you so much, everybody, for being here. Be safe. Take care of yourself, okay?
Okay, you too. So we will see you in the Congress then, right?
We'll see you then. We'll see you in December. Have a great day, guys. Bye.
Okay, you too. Bye-bye.